Our next speaker is Natasha Martin, and here she is. So Natasha is a mathematical, her background is in mathematical biology. She styles herself primarily as a modeler, but she's also professor of infectious disease and global public health at UC San Diego. Her work focuses on modeling infectious disease epidemics. And she also is PI of a NIDA-funded grant investigating ways to optimize HIV and HCV prevention among people who inject drugs worldwide. And so her presentation will shift our focus to rural areas outside the United States and looking at HCV elimination among people who inject drugs, working from modeling and observational data in Mexico. So let me turn things over to Natasha.
Great. Thanks so much, Rich, and thanks to the organizers for the opportunity to speak today. As was mentioned, I'm an epidemic modeler, so I'd love to talk today a little bit about the modeling work that we've been doing, as well as our on-the-ground work that we have been participating in Mexico, and I hope that you'll see many parallels in terms of what we found in terms of hepatitis C elimination insights that are applicable to rural settings and echo much of what you heard in terms of the situation in Oregon. So I'll start first today by talking about our work modeling hepatitis C elimination in the United States. And then I'll shift to work that we have been doing over many years, thinking about hepatitis C in Tijuana, Mexico, the US-Mexico border region. Some initial modeling work that we did looking at what was needed in terms of scale up for elimination among people who inject drugs in Tijuana. And then I'll talk about what has happened during COVID-19 in terms of progress towards hepatitis C elimination, barriers, and opportunities. So starting first with the situation in the US. A recent estimate by Heather Bradley and her team estimated the population size of persons who inject drugs in the United States at just under 3.7 million individuals in 2018. There was wide uncertainty in those in that estimate, but it is substantially higher than other older estimates. So it's 5 times higher than the most recent estimate published in 2011. Those two studies use different methods. Using similar methods to the Bradley methods, her study estimated that the PWID population size is 3 times higher than it was in 2011. So of course there's still uncertainty, but pretty convincing evidence that the PWID population size has grown rapidly over the last decade. So what implications does that have in terms of hepatitis C incidence and elimination strategies? Well, our team at UCSD, this is work led by Jess Karanshima, my fantastic PhD student, developed a dynamic general population transmission model of hepatitis C. This includes transmission and disease progression. It's an age and risk stratified model. And we calibrate the model to demographic data, as well as information on the estimated number of individuals with chronic hepatitis C, the proportion diagnosed, treatment data, as well as this PWID population size, which is growing, and the associated increase we see in new diagnoses. And when we run that calibrated model, we can look at projections into the future in terms of the number of new hepatitis C infections per year. There is uncertainty in that, which you're seeing in the shading here. But overall, our projections are indicating that with status quo diagnosis and treatment rates and this increasing PWID population size, we're likely to continue to see an increase in new hepatitis C infections. So what happens if we just increase treatment? Well, the green dashed line here shows us the impact if we just treat individuals who are diagnosed, showing that we will make some impact in terms of reducing the number of new hepatitis C infections. It will fall short of our hepatitis C elimination targets. And so we need to both remember that we need to additionally scale up diagnosis as well as treatment, and consider combination harm reduction strategies to reduce incident infections as well as reinfection after treatment. And so, treating just the people that walk in the door is unlikely to be sufficient to achieve our elimination targets. Now, this is our national outlook. Much of the expansion of PWID population size has occurred in rural or suburban settings. So what are the implications in these particular settings? Well, this is work that we did a few years ago. It was led by Hannah Fraser and Peter Vickerman and his team at the University of Bristol, and it was supported by the CDC. And it was looking at what is needed for hepatitis C elimination among people who inject drugs, as sort of a rural and urban comparison, just looking at 3 settings in the United States: San Francisco, California, Perry County, Kentucky, and Scott County, Indiana. And what we found is that in a setting like San Francisco, kind of an urban setting that already may have high harm reduction coverage and relatively low incidence, requires less treatment to achieve hepatitis C elimination. Of course, not all urban settings are like this. We have many urban settings that have low harm reduction coverage and relatively higher rates of incidence, but that just gives you an idea. In this study in Perry County, Kentucky, and Scott County, Indiana, these settings had moderate to higher incidence. Scott County, Indiana had an estimated increasing incidence. So in settings that have epidemics characterized by those patterns will likely require greater intervention, as you can see in the bars. So higher numbers of treatments needed to reach hepatitis C elimination. But also in those settings which may have relatively low baseline coverage of harm reduction interventions, scaling up harm reduction, which is shown here in the blue bars, has a really important impact and synergistic impact on reaching hepatitis C elimination, both reducing the number of treatments required to achieve elimination, but also, of course, providing this synergistic impact in terms of preventing reinfection and having other benefits in terms of prevention of HIV infection, fatal overdose, etc. And of course, as I mentioned, the situation is heterogeneous in terms of harm reduction coverage across different settings, but I just wanted to highlight this new work that just came out in Lancet Global Health by Louisa Degenhardt and her team, where she has updated their global systematic review estimates in terms of harm reduction coverage among people who inject drugs globally. And unfortunately, the picture has not changed, with really only 6 countries that they found in the top right-hand figure of this graph, showing high evidence of reaching high coverage of opioid agonist therapy and syringe service programs among their people who inject drugs. The US is a little bit in the middle in that red circle, falling short of coverage targets with an estimated below 20 recipients of opioid agonist therapy per 100 persons who inject drugs, and less than 30 syringes distributed per PWID per year, again, falling well short of these targets and really underscoring and emphasizing the continued focus that we need to have on scaling up harm reduction, both in the US as well as globally, to reach elimination targets. Now, I'd like to shift a little bit to the work that we've done in Tijuana, Mexico, and just to sort of explain the work that we've been doing and the relevance that this has for the United States. So Mexico was among the first Latin American countries which committed to hepatitis C elimination. And our work in Mexico is focused on the US-Mexico border, as you can see here, the top left square. We have focused on in Tijuana, Mexico, which is the border city with San Diego. It's contiguous with San Diego, and it's situated on a major drug trafficking route. There's an estimated about 10,000 persons who inject drugs in Tijuana. There's a very high burden of hepatitis C, with several estimates putting the seroprevalence over 90%. And a more recent estimate of hepatitis C incidence among persons who inject drugs at about 16 per 100 person years, by a longitudinal ongoing cohort study among persons who inject drugs in the San Diego-Tijuana border region that is led by Stephanie Strachty, called the La Frontera study. And I'll mention some data from it several times in this talk. There are gaps in evidence-based harm reduction in Tijuana, Mexico. Less than 5% of persons who inject drugs are receiving opiate agonist therapy. There's negligible syringe service program provision. And one thing that I wanted to emphasize is that in 2014, the federal government put funding towards compulsory drug abstinence programs. These are the main type of drug rehabilitation program available in Tijuana. They effectively act as prisons. And we have several studies indicating that exposure to these programs is associated with both increased injecting risk as well as increased fatal, non-fatal overdose. And so these compulsory drug abstinence programs really can cause harm instead of good. Now, this is some work that that was led by my PhD student, Lauren Marquez, and what we wanted to look at is what was required in terms of achieving hepatitis C elimination among people who inject drugs in Tijuana. So she developed a dynamic transmission model of hepatitis C among people who inject drugs calibrated to data from Tijuana. And like I've already showed you in terms of our work in the United States, again, she found that combination harm reduction reduces the number of treatments needed. That's shown in the increasingly shaded boxes there on the left-hand side. The more harm reduction that we scale up, the fewer treatments we need to reach elimination, preventing reinfection, and has other benefits. But one of the important new points that I wanted to highlight was that she also looked at the impact of what would happen if these compulsory abstinence programs were scaled up. And as I mentioned, because they're associated with increased injecting risk and other harms, what we found is that they can make elimination more difficult, actually increasing hepatitis C incidence and requiring more treatments in order to counteract those negative effects, really making elimination more difficult. And finally, when we looked overall in terms of what was needed to reach Tijuana elimination targets in Tijuana, incorporating the numbers that we would need to treat both the current people who inject drugs as well as former injectors, we estimated that about 1,500 treatments per year are needed in Tijuana if the elimination program started in 2019. So this 1,500 per year was our target in 2019. And so what has happened since then? Well, now I'd like to talk a little bit about what happened during COVID-19 and the progress that's been made on the ground in terms of hepatitis C elimination. So one good thing that has happened is that there has been universal screening and hepatitis C treatment programs in prisons in Mexico. So during 2021, universal screening occurred among the prisoner populations in the whole state of Baja California, which is where Tijuana is located. So the prisons in Baja California have about 12,000 inmates, and virtually all of them were screened. And then in 2022, just under 2,000 incarcerated persons received hepatitis C treatment in prisons in Baja California. That treatment was delivered on site. And so really a good kind of outcome in terms of being able to catalyze those efforts of treatment in prisons. Of course, the COVID-19 pandemic did set back the elimination strategy somewhat. During the pandemic, testing and treatment services were interrupted, but screening was able to continue in addiction centers, hospitals, blood transfusion centers, health fairs, as well as homeless shelters. And in 2022, there were just over 23,000 hepatitis C tests performed in Tijuana, so this was very encouraging. Of course, more needs to be done. We know that many people who inject drugs remain undiagnosed, but testing is ongoing in the settings where it needs to be. However, unfortunately, gaps still remain for persons who inject drugs accessing hepatitis C treatment. So in 2022, our most recent estimates were that there were 361 persons treated in the community in Tijuana. And that's far below our estimated number that would be needed to treat for elimination, that 1,500 per year that I mentioned. And among those 361 individuals who were treated, it's not known how many of those were persons who inject drugs, but it's likely low. So among our Stephanie Strathley's longitudinal La Frontera cohort, among the persons who inject drugs that resided in Tijuana in 2020 and 2021, which was the sort of baseline cohort, none of the individuals who were hepatitis C positive reported receiving any hepatitis C treatment. Additionally, overall, in the state of Baja California, we've received information that only about 25% of hepatitis C treatments that were given across the state were given to people with a history of drug use, any kind of drug use. So again, you know, although this is clearly reaching some of the populations who need it, the current program really needs to continue to focus on how to reach persons with ongoing injection drug use. So why are we seeing that gap and how can we address it? Well, the first major gap that needed to be addressed was the need to bring services to where PWID actually are. So hepatitis C treatment, when it initially became available, was only available at one clinic in Tijuana. It was the HIV clinic. It started being available to individuals with HIV hepatitis C co-infection. Then it was available to anyone, regardless of their HIV status, but it was still only at this one centralized clinic. In the bottom right-hand of this slide, in that circle, Capacites. That is about 15 miles or 90 minutes by bus to the Zona Norte, which is the area in Tijuana, which has the most sort of injection drug use and where most people who inject drugs reside, in that red star. This has been a substantial barrier to accessing hepatitis C treatment as well as HIV treatment. We've known for a long time that in Tijuana, less than 10% of persons who inject drugs who are HIV positive are on antiretroviral treatment, in part because of the substantial barriers that they have in terms of both paying to get to these treatment centers, as well as the time commitment it takes to get there. Fortunately, recently, there's now additionally 5 hepatitis C treatment centers available at health centers across Tijuana. And so we hope that this will catalyze increasing access to treatment, but I really still think more needs to be done. What are some other barriers to care? Well, Eileen Pipiton and Laramie Smith at UCSD did a study a few years ago looking at barriers to HIV care. I think these are very similar to what we'll see in terms of hepatitis C. Through their qualitative interviewing of key stakeholders and community-based organizations, there is continuous discussion for the need for cultural competency. People who inject drugs have multiple needs. HIV, hepatitis C may not be their first need. Housing, food, skin and soft tissue infections, and somebody that can competently understand those multiple needs and address them is key. People who inject drugs in Tijuana also experience stigma and multiple intersecting stigmas, for example, with their hepatitis C as well as injection drug use. And again, a system that can understand and address those will help improve engagement to care. Additionally, we have ongoing concerns with police interference and harassment, which is pervasive in Tijuana and really disrupts access to care and services, as well as unstable housing and police sweeps that we have of where people who inject drugs live has been associated with HIV clusters and outbreaks and continues to serve as a barrier to accessing care in these populations. Additionally, harm reduction access remains extremely limited. So unfortunately, the current president of Mexico, President López Obrador, has shown very little support for harm reduction efforts, cutting funding since 2018. And that has resulted in a really kind of urgent crisis, which has just happened in terms of a current methadone shortage. So this was reported in Vice News just a few days ago. There's a shortage across Mexico as the only methadone production plant has closed there, and it's causing serious ramifications in terms of a lack of access to opiate agonist therapy nationally. Additionally, as I mentioned, syringe service program provision has been severely curtailed in the country since Mexico was reclassified as an upper middle income country setting, and the Global Fund withdrew their funding of syringe service programs in 2015. Our study, led by Javier Cepeda, in Tijuana really showed that withdrawal was associated with both reduced coverage and of geographical coverage of access, as well as the number of syringes that people receive. And our most recent estimate from the La Frontera cohort shows that people who inject drugs in Tijuana report receiving on average 3 syringes per person in the past 6 months. So really incredibly insufficient levels of coverage. So what are the opportunities? Well, and needs in this setting? We still need to focus on bringing testing out into the communities and ensuring that we have adequate diagnosis. Point of care testing, I think, would be a great way of getting testing out and rapid diagnosis for individuals with hepatitis C. We need a continued decentralization of care that has started a little bit. I think it could continue, in particular, mobile vans, telehealth, like that was mentioned in the Oregon setting, I think would be fantastic for Mexico as well. There was a study that was done by Dr. Pipiton and Smith that was looking at the need and acceptability of peer navigation, which you've already heard about today. And there was a very high perceived need and high acceptability of these peer navigators, which individuals felt could help both facilitate access to care, but also address the broader health needs of people who inject drugs, which, as I mentioned, are so key. And finally, I really think we need advocacy for harm reduction. The situation really is critical in Mexico in terms of their harm reduction needs. There's another opportunity that we've been working on over the past few years that I just wanted to highlight, and that is the ongoing work that my colleagues have been doing looking at police education programs. This is a project called Proyecto Escudo, or Project Shield. It is a NIDA-funded study that was led by Leo Beletsky and Stephanie Strafty, and the aim was to align policing with public health in Tijuana. It was a sort of educational training intervention that was bundled under an occupational safety framework, so that there was important engagement by the police officers to really engage with this intervention. In 2015 to 2016, virtually the entire police force of Tijuana, which is over 1,800 police officers, were given this training. And a subsample of officers were followed prospectively for 2 years to measure their self-reported attitudes and behaviors related to interactions with people who inject drugs. And then at the same time, Stephanie Strafty led a parallel cohort of people who inject drugs who were interviewed to track their exposures with this police to see whether this intervention likely actually changed any lived experience among people who inject drugs on the ground. The project was a partnership with the Tijuana Police Academy. It used a train the trainer model, and it was culturally adapted by the instructors to the local setting. It was a 3-hour course that was divided into 3 modules that covered basic epidemiology, prevention and treatment of HIV, hepatitis C, as well as tuberculosis. It covered relevant national and state drug policies, including the recent the decriminalization reforms. And it also covered just general elements of harm reduction, drug use, and public health. And what these investigators found was that the police reported improvements in their knowledge and reductions in drug-related arrests and confiscation of syringes, et cetera, even 24 months after the training of the program. And when we looked at what the PWID were reporting on the ground, what we found was that there was a reduction in self-reported recent incarceration among persons who inject drugs after this educational training compared to pre-training. So the pre-training is shown here in green, the training in yellow, and the post-training in blue on the right-hand side. And this is a nice analysis that was led by Javier Cepeda, which showed this significant change in trend towards this reduced incarceration post-training. And so what we did was we fed the results from that statistical segmented regression analysis into some dynamic models to estimate the impact that police education programs could have on reducing hepatitis C elimination through the mechanism of reducing incarceration, which we know is associated with HIV and hepatitis C risks, not just in Tijuana, but globally. And some work by Carlos Rivera Saldana, my postdoc student, has indicated that if continued for 10 years, this police education program could reduce hepatitis C incidence among people who inject drugs in Tijuana by about 70% and avert new infections, cirrhosis, and hepatitis C related deaths. Additionally, some work by Javier Cepeda that's shortly coming out in a Lancet Commission on Health and Human Rights shows that this intervention could additionally prevent HIV infections as well as fatal overdoses, and together is cost effective and potentially cost saving if it's run and implemented by local staff. So finally, what are the implications for all of this work in terms of hepatitis C elimination among people who inject drugs in rural settings? Well, I think that our modeling work across multiple settings has shown that really this combination harm reduction and treatment strategy is a key component of hepatitis C epidemic control, particularly in areas with emerging and increasing hepatitis C outbreaks, as is the case in many rural and suburban settings. We need to continue to remove access barriers to opioid agonist therapy and expand syringe service programs. Compulsory drug treatment programs, which we have seen in Tijuana, but which also are happening at select places in the United States, and police harassment by the police will hamper hepatitis C elimination efforts and fuel HIV as well as fatal overdose. And we need to continue to address these and make sure that we are offering both evidence-based harm reduction strategies as well as innovative methods to improve interactions with the police. I think there are opportunities to simplify and enable healthcare access among rural populations, including point-of-care testing, mobile vans, pharmacies, these one-stop shop for integrated care that cover the broader needs of people who inject drugs, not just their hepatitis C. Peer navigators you've heard about today as being a critical piece that can help enable those initiatives. And finally, just, I think our work speaks to more broadly this consideration of public health police education programs, which could support hepatitis C elimination efforts, as well as improve the health of persons who inject drugs more generally. And with that, I'd like to thank and acknowledge our many collaborators, particularly Stephanie Strafsey, who has led much of this work in the border region, Gudelia Rangel, our colleague at the U.S.-Mexico Border Health Commission, who works closely and helps us understand what's going on the ground, as well as our funders. This is based on many, many studies that have been funded by NIDA over the years, as well as the CDC. And a quick shout out to our project officers, Peter Hartsock and Rich Jenkins, who have been steadfast supporters of this work over the years. Thanks again, and happy to take some questions.
Well, thank you, Natasha. And it is interesting to see results of work where I've had the privilege of being a PO. One question was, is the cost of HCV treatment in Mexico a barrier?
So hepatitis C treatment is provided free under their national healthcare system. So it is that the treatment itself is not a barrier if they're in the system. What we have seen, as I mentioned, of course, is that there are sort of just barriers in accessing that treatment. And there do remain to be some barriers in terms of just registering for the national healthcare system among people who inject drugs. So, we need a little bit of facilitation to get people properly registered in that system. But once they're registered, the treatment is free.
Okay. And I thought this was a very interesting presentation, just in terms of the different things that you were able to bring together and how, they really relate to the other presentations that we've had this morning.